Eat your lunch while you're learning. And the topic today is the importance of trauma-informed engagement. My name is Holly Mulvihill, and I'm the Interim Director for Quality, Patient Safety, and Accreditation for Shared Health. I am pleased to introduce our speaker, Carolyn Shimmin, and this very important topic during Canadian Patient Safety Week. When we talk about patient safety, we need to take a new approach, one that recognizes a broader view of safety beyond harm, one that recognizes that the absence of harm does not mean care is safe, that all forms of harm matter, both physical and psychological, including those caused by culturally unsafe care. When we partner with patients and the public to learn where we can do better, and engaging with people with lived experiences, we need to be mindful of the potential trauma associated with one's own healthcare journey. Working from a trauma-informed lens enables us to be better prepared to mitigate or handle trauma triggers for patients and themselves and create a safe space. Carolyn Shimmin is the Public and Patient Engagement Lead at the George and Fay Center for Healthcare Innovation. In this role, Carolyn helps lead CHI's strategy on patient and public involvement in health research decision-making. The patient and public engagement works collaboratively with researchers, clinicians, and students to support the meaningful and active involvement of patients, caregivers, families, communities, and members of the public in health research projects and programs. This includes direct support for development of engagement activities with diverse groups, facilitating relationships, and the development and delivery of resources, training, and education. Carolyn has a Bachelor of Journalism, combined honors, political science, and a Master of Gender Studies. She is currently a PhD candidate in the University of Manitoba's Community Health Sciences program. I am very pleased to have Carolyn present on this very important topic. There will be time following the session to have questions and answers. Please feel free to write down your questions in the chat, and they will be looked at after the presentation. So sit back, reflect, absorb, and thank you so much, Carolyn.
Thank you so much, Holly, for the introductions. And thank you so much for everyone coming and attending today's session, taking the time out to attend. To start off with, I know that today's topic is not an easy one. And for that reason, I really encourage everyone to practice gentleness and self-care during this session. If feelings come up and you need to take a few minutes away from your computer, that's okay. Make yourself a cup of tea, slowly sip a glass of water, stretch, do whatever it takes for you to reconnect yourself to the present. And should you need a little additional support following today's session, Ogai is going to put some resources in the chat box, both for our Manitoba folks. There is a list of free and low-cost counseling resources, and for those nationally, Ogai also has some resources. So should you just need a little extra care afterwards and someone to talk to, those resources will be there in the chat box. Victoria, maybe we can pull up the slides. Thank you so much. Oops, and I think it might be in prison. Oh, there we go. That's amazing. Thank you so much, Victoria. So maybe the next. I'd first like to start off by acknowledging that myself and the Center for Healthcare Innovation are located on the ancestral and current day lands and waters of the Anishinaabe, Cree, Ojibwe Cree, Dakota, and Dene Suline people, and on the national homeland of the Red River Métis. In northern Manitoba, we acknowledge the ancestral lands of the Inuit and gratefully acknowledge that our water is sourced from Shoal Lake 40 First Nation. And as a white settler myself on these lands, I feel immense gratitude to Indigenous peoples who have been the caretakers and who have lived and worked on this land since time immemorial. And in coming together today, we respect the treaties that were made on these lands. We acknowledge the harms and mistakes of the past. We recognize the ongoing present day colonial violence that is faced by Indigenous peoples within the healthcare system, education, justice, child welfare, and government systems, as well as healthcare. And we dedicate ourselves to moving forward in partnership in a spirit of reconciliation and collaboration. And when we talk about patient and public engagement in health research, it's in fact Indigenous research methodologies that are at the forefront, and Indigenous scholars and researchers and communities that we should be looking to. It's our belief that trauma-informed engagement is an integral aspect of social justice and health equity. Maybe the next slide, Victoria. So here's a little bit of an overview about what we're going to be chatting about today. We'll first look at what is trauma, and then why is it important to understand when we think about engagement? What does trauma-informed engagement look like? What's the difference between safety and comfort? How do I put trauma-informed engagement into practice? And then ways to integrate self-care into your work. Maybe the next slide. So because this series is accredited by the Royal College of Physicians and Surgeons of Canada, I'd like to disclose, first of all, that I am employed by the George and Fahey Center for Healthcare Innovation as the Patient Public Engagement Lead. So as mentioned, I work in the area of patient and public engagement and health research, meaning I get the privilege of working collaboratively with researchers, clinicians, decision makers, and people with lived and living experience of health issues, their families, and communities. And I actually have this quote. For those who know me, know this quote. I have this quote hung on my wall in my office as a reminder that as human beings, we are complex. We simultaneously inhabit many different social locations. And when we come together, we all, as individuals, bring our own political, cultural, economic, subjective, and experiential knowledge to the table. And so what this means is when we do engagement, and some of the best engagement, in my opinion, it can be messy, it can be uncomfortable, it can be complicated. But as Brene Brown says, vulnerability is the birthplace of innovation, creativity, and change. And so sometimes the incredibly valuable experiential knowledge that's brought to the table by people with lived and living experience of health issues, families, and communities can be intertwined with experiences of trauma. Sometimes health researchers and clinicians also bring experiences of trauma to the table. And so we've learned over time that the incorporation of trauma-informed engagement approaches and strategies plays an integral role in the creation of safe and inclusive spaces for collaboration and co-design in health research and health systems projects. So firstly, when we start talking about incorporating trauma-informed practice into engagement, what do we mean by trauma? How do we define it? Well, trauma is defined as one or more experiences that overwhelm an individual's capacity to cope. So a traumatic experience can harm a person's sense of safety, their sense of self, their ability to regulate emotions and navigate interpersonal relationships. And long after a traumatic event occurs, a person with trauma can often feel shame or helplessness, powerlessness, and intense fear. And it's really important for all of us to understand that trauma is a widespread, harmful, and costly public health issue. And evidence does show that people who come to the healthcare system who have significant histories of trauma to begin with, it can affect their physical and mental health, their responsiveness to health interventions, and their ability to access appropriate healthcare services. And there also needs to be an understanding that healthcare systems that are intended to provide services and supports to individuals may themselves be trauma inducing. For example, the use of invasive procedures in the medical health system or restraints in the behavioral health system. All of these things can be re traumatizing to individuals who may have already experienced significant histories of trauma before even entering the system. So, when we talk about trauma informed practice, what do we mean? Well, it all begins with building an awareness among everyone, whether you're a health researcher, a clinician, a decision maker, a caregiver, a patient partner, a community member. It's building that awareness that trauma is a common experience, that the impact of trauma can be central to one's development, that there is a wide range of adaptations that people make in order to cope and survive trauma, and that there is a relationship between trauma and substance use, as well as mental and physical health concerns. And it's really important for people to understand that there's different types of trauma. Trauma can be experienced early in life, including child abuse, physical, emotional, psychological, and sexual, neglect, witnessing violence, and disrupted attachment. But trauma can also occur later on in life through experiences such as violence, accidents, natural disasters, war, sudden unexpected loss, and other life events that are out of one's control. And the intricacies cannot be overstated, as there's a variety of dimensions when it comes to trauma as well. Its magnitude, its complexity, its frequency or duration, at what age trauma occurs, and whether it happens from an interpersonal or external source. And there are typically what they call 5 types of trauma. So first of all, single incident trauma. This is when an unexpected and overwhelming event occurs, such as an accident, a natural disaster, a single episode of abuse or assault, a sudden loss or witnessing violence. In the healthcare system, it can be an invasive medical procedure, an unexpected diagnosis, or a harmful interaction with a doctor. Complex or repetitive trauma, this is when abuse is ongoing, such as domestic violence, living in a war zone, or ongoing betrayal, and it often involves feeling trapped both emotionally and physically. Developmental trauma results from exposure to early, ongoing, or repetitive trauma as an infant, children, and youth, such as neglect, abandonment, physical, sexual, or emotional abuse or assault, witnessing violence or death, and or coercion or betrayal. And it typically occurs within a child's caregiving sphere and can interfere with healthy attachment and development. And intergenerational trauma describes the psychological or emotional effects that can be experienced by people who live with trauma survivors. So, what is often seen as coping and adaptation patterns developed in response to trauma, including alcohol and substance use, can be passed from one generation to the next. And then finally, there's historical, structural, or systemic trauma. So, historical trauma is the cumulative emotional and psychological wounding over a lifetime and across generations emanating from massive group trauma. And these collective traumas are inflicted by oppressive and dominant systems of power, like governments. So, examples of historical trauma include genocide, colonialism, slavery, and war. It includes things like forced displacement from home, discrimination based on race, ethnicity, religion, gender identity, gender expression, sexual orientation, ability, and class. And so when we think about even just engagement in Canada, it's really important for trauma informed engagement to include that examination of the role of colonization, both past and present, in violence against Indigenous peoples, including looking at the legacy of residential schooling and the 60s scoop, as well as ongoing issues of discrimination and racism. And this leads us to what we call structural or systemic or institutionalized trauma. And this refers to the way that people are harmed by larger systems that many of us rely on, such as educational systems, political systems, criminal justice systems, employment, and healthcare systems. And these systems are set up a lot of times to serve a small group of people, often at the expense of larger groups of people. So some groups' needs and voices get set aside, while other needs and voices tend to be centered. And so the people who are not being served by and often harmed by these systems can be traumatized by these systems. So systemic trauma really refers to the emotional and psychological harm from inequities enforced through public policies and institutional practices, such as discrimination in economic opportunity, employment, education, housing, and healthcare. And unlike individual and interpersonal trauma that focuses on an individual's response to trauma, systemic and structural or institutionalized trauma really requires a collective response, meaning we all must be committed to responding. And so the effects of trauma are diverse and they vary from person to person, from minor disruptions to debilitating responses, such as feelings of powerlessness. And some of the coping or adaptation skills that come up is difficulty regulating emotional reactions, or listlessness and dissociation. So as we start to think about why it's important to understand trauma when it comes to engagement. First of all, because traumatic events by their very nature set up a power differential where one entity, whether it's an individual, an event, a system, or a force of nature, has power over another. So an individual's experience of these events or circumstances are shaped in that context of powerlessness and feelings of humiliation or guilt or shame or betrayal or silencing. All of that helps to shape the experience. And so it's really important in interpersonal relationships, which is the crux of engagement, right? That these feelings of powerlessness are not being reproduced or reconstituted in any way in our engagement strategies and the way in which we come together and interact. And so we know people with lived and living experience can come to engagement with a variety of life experiences that shape how they feel, what they think, and how they respond when interacting, say, with healthcare researchers or healthcare professionals. Some partners may have previously experienced boundary violations by someone close to them, interpersonal trauma, or even forms of oppression within the healthcare system itself. So recognizing this as any member of a team, having that understanding can be really powerful for everyone involved when you're engaging. So now that we have a bit of an understanding of what trauma is and why it's so important when it comes to engagement, we can move towards what it might look like in engagement. So in Manitoba, a while back, we started thinking about how do we move more towards inclusive engagement. And through conversations and discussions and engagement with community, we started to really collaboratively think about the incorporation of something called a trauma-informed approach and an intersectional approach. And this is where the Valuing All Voices framework was born and informed and refined by communities within the province. So this is the framework, and it was created to complement other types of engagement frameworks, such as the Strategy for Patient-Oriented Research's Patient Engagement Framework. And it really just builds on some of those integral aspects of relationship building, such as self-awareness, education and communication, understanding, acceptance, and trust. And so as part of the first component, self-awareness, this is really important. So even before we start engaging and developing practice, we really have to first think about how ourselves we are committed both individually and when our team comes together to really ongoing critical reflexive practice, because we start to understand the impact of systemic and institutional trauma. We must also consider and begin to consider how the social locations in which we personally inhabit are connected to these larger systems of power and oppression. And so this is a neat, this is kind of a visual representation by Dr. Stephanie Nixon. It's the coin model of privilege. And really what it shows is that privilege and oppression are two sides of the same coin, which is part of the system of inequality. So for there to have people having unearned disadvantages simply because of who they are, there also has to be people who are getting unearned advantages simply for who they are. So it's connected and it's one of the same. So it's it's a neat little tool that you can look at as well. And part of self-awareness, so that's so important when it comes to trauma-informed engagement, is that commitment, right? So whether you're a healthcare researcher, a healthcare professional, or a decision maker, or a patient partner, it's really important to first critically think about what your own personal values and experiences and interests and beliefs and political commitments are in the area of health that you're going to be researching and working in, or if you're in health systems on a health systems project. And then how do these personal experiences relate to some of the socially constructed locations you inhabit? So race, ethnicity, gender, identity and expression, sexual orientation, ability, all of these different locations, and then larger systems and processes of oppression like racism, colonial, sexism, ableism, all of these things in the area of health that you're going to be looking at in research. And you can start having conversations about how you can become more aware of and take advantage of opportunities where you can challenge each other's ideas and renegotiate power within your team. You can start having conversations about what resilience looks like, feels like, and means to you, and also how you think you can address, how you can make sure that everyone's voices and perspectives are included, and that we address health inequities as well as issues of social justice. And we have a little readiness to engage workbook that has some of those individual questions and team questions, and we can definitely send that out, I think, following the talk too, if people are interested in taking a look further. So safety and trustworthiness is one of the core components when we're thinking about trauma-informed engagement. And really what this means is taking the time to build relationships, being flexible, being adaptable when it comes to meeting and coming together, allowing time for storytelling and laughter. And we oftentimes tell teams to prepare to have a few of the initial meetings completely dedicated to relationship building. And one thing a lot of our teams start off by doing is having a conversation around safety, because safety can be defined in many different ways depending on the person. And what we found over the years is each conversation is quite unique with different teams. And so first of all, researchers, healthcare professionals, patient partners, everyone coming together to co-design and work together can talk. First of all, we look at physical safety. So what does it mean to you? What does it look like to you? And what does it feel like to you? And some of the examples that sometimes come out are choosing to meet in a community setting versus an academic or a hospital or healthcare setting, creating warm and welcoming spaces, meeting people where they're at. And then we move on to, oops, sorry, I wasn't up there. Then I talk too much. And then we move on to emotional and psychological safety. We talk about what it means to you, what it looks like to you, and what it feels like to you. And there can sometimes the conversation, we talk about the collective commitment to the belief in the resiliency and strength of both individuals and communities, the idea that recovery and healing of trauma is possible, and that the answer often lies within individuals and communities. We have conversations around the importance of the role of bearing witness to people's stories and upholding space for people's stories to be shared, being fully present, actively listening and reflecting, and about sitting in non-judgment of the coping and adaptation skills that people may have developed in response to trauma and learned how to have their needs met. And it's also moving away from the idea of what's wrong with you to really thinking about, have you had any life experiences that have impacted your health and well-being? And also when we start talking about cultural safety, what it means to you, what it looks like to you, what it feels like to you, sometimes there's conversations around, well, yes, we need to continue to do ongoing critical reflexive practice, both as individual team members, but as a group. We commit to continuing to take classes and training around anti-racism and anti-oppressive training and practice, and continuing to learn about the impact of ongoing present-day colonial violence within healthcare institutions. And then sometimes when we talk about spiritual safety, what it means to you, what it looks like to you, what it feels like to you, examples might be maybe having some time before a meeting to come together with an elder, or integrating certain ceremonial aspects into the engagement practice itself. And through all of these types of discussions, teams can start to begin to build guiding principles that can be reviewed on an ongoing basis. So it creates kind of a shared language for everyone, whether you're a researcher or a patient partner or a healthcare professional, to kind of those moments where you need to identify where there's some conflict, that there needs to, an important conversation has to go down, or there's a power imbalance that you think needs to be addressed, we can always all refer back to the guiding principles. And it also helps groups to differentiate between what is uncomfortable, so requiring the need for everyone to really lean into a difficult conversation, versus what is unsafe, meaning requiring the need to ensure supports and additional resources are in place. So when we start to explore what is the difference between unsafe and uncomfortable, this is a really important conversation that I think you can have at the very beginning, and it goes really well with the guiding principles exercise. And it's mainly because sometimes people feel that safety means being able to comfortably express your opinion and not be judged. But there is times where if you say something that is harmful, so if you say something that might be considered racist, sexist, homophobic, or transphobic, ableist, sanist, sizist, classist, any of those types of things, you will be called out. And it may feel uncomfortable, but it's not unsafe. And it's good to start having those conversations up front and letting everyone know that this is the behavior that we'll model as a group together and as a team. And so that comes into, sometimes we get questions around calling in and calling out. So when someone says something that is harmful, what do we do? And it can be a difficult situation, but of course, to keep spaces safe and inclusive, we really need to address these things. So Harvard has this great guide around calling in and calling out. It's the Harvard Diversity, Inclusion, and Belonging group. And we'll just take a look. So when someone causes harm, there's two different options, right? So calling out means you're bringing public attention to an individual or a group or an organization's harmful words or behaviors. And then calling out means, oh, calling in, and then calling in really means an invitation to a one-on-one or small group conversation. Um, and this, and oops, sorry, a one-on-one or small group conversation to bring attention to an individual or group's harmful words or behavior, including bias, prejudice, microaggressions, or discrimination. And so some of the reasons that we do this, of course, is to stop the perpetuation and negative effects of harmful words or behaviors, to create a compassionate space for people, and to lean into having tough conversations, which is a critical part of trauma-informed engagement. And so sometimes some of the considerations are like, of whether you're going to do the calling in or calling out can be just how open people are, where you're at, the influence, the safety, and the urgency of the matter. So if things really need to be addressed right away, it might be that you have to call out. And so what does that look like? So if you're calling someone out, these are some of the suggested things. That's not our culture here. That's not our values. It sounded like you said, is that what you really meant? I need to push back against that. I disagree. I don't see it that way. I need you to know how that comment just landed with me. It sounds like you're making some assumptions that we need to unpack a little. And then calling in looks a little bit different. And this is when you're inviting into or leaning into some difficult conversations. And that's, I'm curious, what was your intention when you said that? How might the impact of your words or actions differ from your intent? How might someone else see this differently? Is it possible that someone else might misinterpret your words or actions? Why do you think that is the case? Why do you believe that to be true? So this is when we're calling in and to have those conversations. Some of the tips that they usually say is people come sometimes and they had no intent to cause harm and they said something and it caused harm. So thinking about criticizing the behavior and not the person, being very specific about what they said that is harmful and why it's harmful, trying not to condescend, deciding whether to call in or call out, and hope for the best and just get prepared that it could be a tough road, but that it's well worth it because you really, especially if you're facilitating engagement events, you want to model that behavior with people, the behavior with the team, right? And show that you are there to make sure no one is harmed in your engagement. When you are called out, so perhaps you've been called out, some of the most important things to do is to, first of all, pause, to listen. So oftentimes we want to clarify that wasn't our intent, but really you need to take a step back and listen, acknowledge that you've caused harm. So it may have not been your intent, but you have caused harm. Then reflect and then repair the harm that's been done. And that's not having the person calling you out be the one to educate you. It's on you to go and read more and learn more about how to never do this harm again. So what are some additional ways that we can integrate trauma-informed practice? So safety and trustworthiness is one of those key components. Things like welcoming introductions we talked a little bit about, but really believing in the primacy of relationships when it comes to engagement. As much as we really want to, oftentimes if we're doing a research project or a health systems project, we want to move through things, we want to get through the agenda, really foregrounding the importance of the relationship itself. So taking time to slow down and making sure that you're allowing space for storytelling. And it could take up a meeting and you just have to kind of be more flexible. adapting the physical and online space to be warm and welcoming. So really listening to what people would prefer as far as spaces. People might say, you know, we want to sit in a circle, or we want to be facing one another, dimming the lights, allowing space to move around. When it comes to online engagement, having one-on-one conversations with partners as to whether they do have a safe space to engage online in their house. And it might mean connecting with a community organization near their house, where you can get a room and a computer for them to go to if they have a space where they may have lots of people living and they don't have a space to really be able to engage. Providing clear and accessible information. Safety includes empowering people with the information in ways in which are accessible and that they can really meaningfully contribute. Ensuring everyone understands confidentiality. Sometimes we say things we learn together can be shared, stories we tell one another must stay here. But having those conversations, creating a crisis plan if a team member is in distress, coming to any type of engagement, first of all, with an available list of supports and resources that are easily accessible by partnership members within the community. So free walk-in, in-person phone and online supports on hand should someone need some additional supports. You can volunteer to sit with someone while they're making a call and setting up an appointment. And it's also important to think about grounding techniques. Should someone be overwhelmed, including yourself, it's always a good thing for self-care as well. So techniques like deep breaths, sipping a glass of cold water slowly, focusing on an object in front of you. Sometimes in engagement, we recommend having a separate quiet room, or in the case of online engagement, having a separate breakout room where people can go if someone needs a few moments to themselves or needs to talk with someone else or do a grounding exercise. And then finally, demonstrating predictable expectations and scheduling meetings consistently. So to build trust, it's really important to let patient partners and people with lived experience set the tone and the pace of meetings, model consistent behaviors, and have that feeling of being reliable and supportive. And choice and collaboration, again, is a really important part of the conversation, because trauma often leaves people feeling powerless and having had little choice or control over things. It's really important throughout your engagement to offer as much choice, how people prefer to be contacted, who will be involved in certain decisions, how budgets will be allocated, the priorities and goals of the project, and really being forthright about that and constantly thinking about all of the different choices that need to be made, and making sure people have a say in it. Eliciting people's priorities, as well, brainstorming how to address any barriers in engagement. So even talking about who's missing and what type of barriers might we want to think about addressing. Making sure, what do you need to get out of this engagement to make sure it's worth your time? So really thinking about other people's priorities and hopes as well, inquiring and about whether the involvement of a caregiver or a family or a friend might also help with some of the engagement. Also making sure that statements really that you make it makes collaboration and choice explicit. So let's figure this out together. What's most important for you? Where should we start? It's really important that we'd work on this together. And then always making sure that you're getting people's perspectives. And the importance of bearing witness, of course, is so important. And the big thing is to think about that we bear witness to people's stories all the time, family, friends, coworkers, when we read books, when we watch movies. And so the big thing is just upholding that space, to listen, to actively listen, to reflect back what people are saying, to acknowledge the strength that it took them to share their story, and being fully present when someone is telling their story. And people may share their story for a number of reasons. It's not just to share their experiential knowledge for decision making, but it might be a valuable way to process their experience or obtain empathy and support from people, lightening your emotional load, asserting your own agency as well. And there's so many positive effects of affirmations, right? Following up with, that I see you, that must have been so tough. You're so strong. Really acknowledging effort and strength when people tell you a story, offering appreciation and understanding, and really recognizing success and all that people have overcome and gone through. A neat thing, Brene Brown, I don't know how many people read, but she really laid out what empathy is. And empathy, she was saying, is essentially listening to someone's story, identifying the feeling that they must have felt, thinking back of a time where you felt that feeling. And you may have never gone through the same experience, but you may hear like the idea of powerlessness or feeling hopeless. And you can probably within your life identify a time that you experienced that as well. And then saying, you know what, I see you. I've felt that way before, and that must be really tough. And that's really what empathy is about, that you may not have gone through the same experience, but you can relate to that feeling. And boundaries are such an important aspect of empathy as well, because the kindest thing we can do is make sure that all of us are on the same page about what is okay and what is not okay, and having those boundaries respected amongst us all. And so I love this idea that boundaries are really a prerequisite for compassion and empathy. And so we come to self-care, which is one of the most important. We don't talk about self-care enough, do we? Whether in health research or in health systems work. So really, some of the things that we talked about around grounding, so learning more about grounding techniques like breathing, deep breaths, sipping a glass of water, finding one that works for you sometimes when you're having big feelings. Um, and also sometimes doing that in between, say you just had an engagement session and now you have to move on to another meeting, taking that time for a couple of minutes and doing a grounding session for yourself. One of the most important things about trauma-informed engagement is always having a debrief plan with individual partners, but you can also create a debriefing plan for yourself with colleagues as well. So, ooh, sorry about that, as well. Having variety in your day and roles, so mixing in social with maybe some quiet time as well is really important. Thinking about attending continuing education sessions, thinking about mindfulness-based stress reduction techniques. There's great courses out there. Taking scheduled breaks throughout the day for reflection, socializing, exercise, eating, and just to get away from your work tasks. Developing, of course, your personal debriefing plan with peers or your supervisor, and then setting realistic goals for yourself as well. These are all super important too, because you got to look after yourself as well. And I guess to end with what I always say is, it's an absolute privilege to bear witness to someone else's story, to be present, to make people feel valued and seen. And we all, at some point in time, will need that too from someone else. And we can only hope that it comes with the same level of compassion and love. So thank you so much, and I'll open it to questions.
Anybody has any questions, you can go on the chat or raise your hand. There's additional resources, yes.
Yeah. It's a lot to take in, so I completely understand if people are kind of like, oh, I see Patty.
Hi, it's great to be here. I came for a refresher because I know these are ideas that you're continually deepening, right? So I really appreciate that. I wondered, this is a kind of a U of M specific question, but maybe a Winnipeg specific question. But we talk about the physical space, and anti-ableist perspectives would mean that they have to be safe from a COVID perspective. To be in person means that we have to appreciate that we may not know people's full health histories or the people they're caring for. It's a bit of a comment and question, I guess, but the idea, like, to my knowledge, we still can't get consistent ventilation information about our meeting rooms on campus. So do we know of places that are excellent to book in the community of Winnipeg that have done this work? Do we have some guidance in that regard of how to make airborne infectious spaces safer for people? That's sort of my thing, because I feel like we're not, for some reason, this disconnect is still happening and it's affecting our ability to meet in person.
Absolutely. I think that's such an amazing question. And that goes to how, like, safe spaces can mean so many different things. And that is such an important one, from that perspective as well. And moving beyond simply just saying, well, we have hybrid options. So you can be involved at home or in person, but actually finding options. I would say that I would love to figure out some of those organizations that have taken consideration into. We use lots of different community organizations and spaces that people have recommended, that the people who we are engaging feel most comfortable in, whether it's community healthcare centers and things like that. Where they feel most comfortable. But I think that would be, because that could be very much a reasonable question to ask on behalf of a person with lived experience, like where exactly is. So I would say, I think that's a great undertaking that we need to take on, at least in Manitoba, and for our friends across Canada, maybe that's a question for all of us to ponder as time goes on. Awesome question, Patty.
Thank you. There is a question in the chat. Can you give some examples of how trauma-informed care can be applied at triage in the emergency room?
Ooh,
That's a doozy.
That's such a important aspect as well. That's a big one, right? Because that is a space in which people are coming with so many different things. I think some of the basics of even slowing down and listening to people. Oftentimes we want to rush through, probably in triage, just, what do we need to fix at the moment? But if there are opportunities to have conversations and really listen to what's going on with people, making people feel more seen and heard. I definitely think those would be things. Ogai, do you have any suggestions as well? Because I know you've worked as a social worker within the healthcare system.
I think if at any opportunity we think of self-determination as a key space by giving power back to folks is so important. Asking, what supports do you need? Do you need a glass of water? I think the humanistic approach of would you like a glass of water? But also remembering in hospital, there is cultural supports available. Do you need a support person? Bringing someone else, because sometimes having someone from the same background as you as a support person can make a whole world of difference when you have no one and you're coming from like language barriers or whatever it may be. So yeah, just that human relationship piece, simple things, and providing power and self-determination whenever possible.
Oh, I love that. Ogai, the idea too about choice, right? As much as possible. Oh, that's so great. I think I see, is it Ray?
Yeah.
Briefly, I wanted to just add the about the ER question as well too, as somebody who has been in that space from the patient and caregiver side. I remember the first time my son coded, and I remember intuitively understanding what it meant to back the heck out of the room. Well, in this tiny room, it was filled with a whole bunch of people doing their thing. And one of the greatest gifts I got in that moment was a physician who hung behind, because I knew in that moment there was just nothing going on in my brain. I was blank. Was someone who was willing to have just the most benign conversation with me in that space, to just help me recalibrate and not feel like there was just zero function. I shut off entirely, and he helped me reboot my brain system in that moment, and that was a really important thing for me personally. So I definitely recommend that as an option to throw into there as well too. Carolyn, I wanted to add, I love what you mentioned about storytelling, because I feel like this is something that comes up with me in consultations on engagement a lot, is people saying things like, so how do we cut down the length that happens with story time or storytelling? And I keep telling people that is, in the nicest way possible, that's so offensive. That's basically, how do you tell people to shut up? And it just, so have there been compromises and practices that you have found in that space that I can recommend as opportunities for people to think about how to refine that space? Because obviously I come from a demographic within the disability community where we are talkers as caregivers, and so you kind of get used to that culture and that understanding that this is still a new space. You've been given attention, you're finally being heard, there's so much going on in there. But I feel like that there is something to be said about, realizing the time. Are there best practices that you've heard in this space that I can offer to other people?
Oh, that's such a great, because I am like you, a huge proponent of, I believe that we should have so much space for people to share their story. And oftentimes if we listen actively, we realize that people are informing the research process in the storytelling, right? Because there are elements that then can help inform the decisions that we have to make as we design the project. We've even the cool thing is, in some projects, we've even tried to integrate storytelling as the participatory approach at a decision phase. So I think in one instance, we, at the interpretation of data phase, going to present a bunch of data and then ask people what they think. Well, let's turn this around and let's use a storytelling method by saying, you know what? Numbers tell stories, but they don't tell us the whole story. What story are the numbers telling? Now, how does that relate to my own personal story? And then what story is not being told? And then integrating those types of participatory approaches just naturally lean right into people's ability to truly contribute to decision making while still naturally having conversations and telling stories. So fine, yeah, I love trying to integrate that into the decision making process, and understanding that people's stories can definitely inform decisions if you sit and actively listen. I think sometimes we're used to, like, what do you think about this? And what do you think about, but people are telling you what they think about it, but they're telling you in a story oftentimes. Thank you.
Thank you. I'm going to read a couple of questions if time allows. Yes. You had mentioned the importance of boundaries as these related to empathy. And I'm wondering if it is a good idea to talk about boundaries as a team at the start of a project and what that looks like.
Yeah, boundaries, I think it's such an important piece of the puzzle. um, because yeah, I think I remember Brene Brown writing that the kindest thing is to be super clear about what's okay and what's not okay as a group, and having that conversation. I think your guiding principles are really going to allow lay out a lot of what's okay, what people want to see when they think about safety. So having those guiding principles and having that conversation out front is an integral part, and that you can then refer back to continuously when you feel like there's a boundary violation or there's something. You can obviously go back to remember the conversation with our guiding principles. Let's review the principles again. Being open to adding things sometimes throughout as we learn from one another and as we build that relationship as well. I know there have been conversations around boundaries as well, and empathy in the way that when we are sharing a story, it's okay to feel those feelings like a frustration or anger, but where it's not is directing it towards someone. So having those conversations around that piece as well, and setting those boundaries. And then I think if you are someone who's facilitating the group, the big thing is also you modeling those boundaries as well. So calling people out if they say something that's harmful, and making sure that there's that understanding as well. So lots of boundaries.
And one more, I think time allows here. How might these approaches need to differ when engaging staff teams in conversations on changing workplace culture? And added to that, I'm thinking about the power over dynamic at play.
Yes, absolutely. I still like, I know people feel really might feel uncomfortable, but having staff conversations around safety and building guiding principles about how we're going to have conversations together and how we're going to collaboratively build spaces together. I think that's still super important, whether it's a team, a staff, as you move forward as well, and kind of outlining those principles, of how we're going to deal with disagreements and so on. So I would still recommend some of those, some of the, what does physical, cultural, spiritual safety mean to me, look like me to me, and feel like to me? Because oftentimes we don't talk about that within workspaces as well, right? And how important it is to have that understanding with one another, even just the way we communicate, right, with one another.
Just quickly wanted to add the role of vicarious trauma when we are working with folks who, because we're witnessing and bearing, and holding and creating space for folks. So I think when it comes to power dynamics, a cultural shift within our work is important. And it starts off with having these conversations, guiding principles from up down, not from down up, like trickling down. So really coming together as a team and creating a space of inclusivity and support, resources that staff can also have, and having space to just be in solidarity, support one another, take breaks, go for walks, having staff come together, doing little celebrations, celebrating each other. I think that can go a long way when it comes to self-care.
That's so important. I think, yeah, self-care. We need to talk about self-care more.
And a comment, just a comment in gratitude for this talk from Karen Burgess. The shift to trauma-informed care and systems and the many tools and skills discussed require a move away from time-crunching messages received in our culture and current system like flow. Do more with less human resources and be open to being patient in relationships, making space for breaks and connecting within teams and with the people we serve.
What a great comment. That is fabulous.
I think that's a great way to end this session. This has been very powerful, Carolyn. This is, you know, we are moving inch by inch with this, engaging more with patients. We need to know how to do this in a very safe way, creating those safe spaces for our patients. We need to know where we can do better. We need to learn from them. And how do we do that in a very safe, trauma-informed lens? I really appreciate this topic. Thank you.
Thank you so much. And thank you, everyone.